first of all, please introduce yourself.
Sure. Hi there. I'm Dr. Pam Theriot. I'm so honored to be here this evening with you. And I am from Louisiana in the United States. And my talk today is going to be about building a dry eye protocol. And we'll be going through the steps that you could create in your own clinic to find dry eye patients and treat them adequately. So I'm so excited to be here. And I will see you in a moment.
Thank you, ma'am. In our program, I'm honored to introduce our first guest speaker, Dr. Pam Theriot, ma'am. She currently serves as the clinical director at the Dry Eye Relief Center at Lux Eye Specialist in United States. Dr. Pam, ma'am, is an internationally known optometrist and a specialist in dry eye. She has spoken on many stages around the world and is loved the way she explains eye health topic and in a very simple and practical way. Today, she will be speaking on the topic ocular surface disease, keratitis sicca, and blepharitis. So, at this time, I would like to respectfully invite Dr. Pam, ma'am, to share her insights with us.
Thank you so much for that warm welcome. Do you see my screen?
Yes, ma'am, I am seeing your skin.
Creating a dry eye protocol. Okay.
Okay.
So as Fatima introduced me, I'm the clinical director of the Dry Eye Center at a clinic in Louisiana. I wrote a book called Alleviate Dry Eye that is patient facing so the patients could walk themselves through a few lifestyle adjustments to alleviate their dry eye symptoms. And in 2025, just this year in January, I was honored to speak on a TEDx stage in Vancouver, Canada, to bring optometry to the world to show the importance of having an eye exam when living in a screen-filled world. I also played a role in the Tear Film and Ocular Surface Society's lifestyle workshop, where I was a public awareness committee member. And tonight we're going to go through, these are my financial disclosures, companies that I work with closely to do advisory and on their speaker board. Tonight we're going to really dive into the TFOS DUES 3, or Tear Film and Ocular Surface Society Dry Eye Workshop 3, which was published this year to give a guidance of how to treat dry eye. And we're on the third session of TFOS DUES. This last one being published in 2017 and this one just this year. We're really looking to refine how we treat dry eye and subcategorize it so that we are looking at the proper portion of the ocular surface and treating it adequately. Tonight, I'm going to go through two of the three subsets: the tear film deficiencies and the eyelid abnormalities. We'll leave ocular surface abnormalities for another time. And then we'll review the treatments and managements of how we would restore homeostasis to the ocular surface and allow the eye to continue working at its optimal capacity. So through this workshop, a few algorithms were created in order to walk you through how to treat the patient. If you would like to see these algorithms in real time, they were published in the Journal of Ophthalmology, and you can also go to the Tear Film and Ocular Surfaces website, which is tearfilm.org. And this is the second algorithm that looks at the eyelid abnormalities. And the third algorithm is the ocular surface abnormalities. It looks more into neuropathic and neurotrophic keratitis. The way that I like to start treating my patients in the clinic is by starting with a symptom survey. This gives me an idea of what my patient is experiencing and what my goals might be to help them as I'm treating them. I listed all of the different questionnaires that are currently available, and I just want to highlight a couple of them that I've used in my clinic. So this one is the speed test, which looks at symptoms, the frequency and the severity of such symptoms, and the patient is able to, in questions 2 and 3, report the frequency that they have these symptoms. and then the severity in section 3, and come up with a number out of 28. The higher the number, the more the patient is symptomatic of their dry eye disease, and our goal is to reduce that number. It's a quick and easy way to track our patients, so I like using a symptom survey. This is the Ocular Surface Disease Index 12, and the TFOS DUES 3 report shortened this ocular surface disease index to just 6 questions. It makes it a little bit shorter for you to go over with your patients. And it also eliminated a couple of older terminology that was used in the vision section when looking at the OSDI, or the original, said looking at an ATM machine. And since we don't use those regularly, they omitted that language. It's still statistically significant, and just using the 6 questions, you'll be able to follow your patients easily and know if your treatment management is going in the right direction. So we're going to go over a simple workup for dry eye disease and looking specifically for comorbidities of ocular surface diseases. As I said, I always start with a survey, either the SPEED or now the OSDI 6. Then I'll want to look at corneal staining, Lisman green, and fluorescein, do a tear breakup time, or you could put the patient behind a manual keratometer and look at how quickly those rings dissipate. A Schirmer's testing with a Schirmer's tear test, evaluating the lid margin, pushing on the lid margin to look at the meibomian glands and the quality of the meibum coming, checking the lid seal using a light test, and then of course, always checking for corneal sensitivity to rule out neurotrophic keratitis. The best part about this simple workup is that you don't need any fancy machines to get a good understanding of your patient's ocular surface. This is a segment that I took from the ASCRS's algorithm to treat dry eye before going towards ophthalmic surgery, be it refractive or cataract surgery. And they look at the clinical exam in 4 simple steps: look, lift, pull, and push. So when they look at the eye, they want to evaluate the blinking, the lids, lashes, and the interpalpebral surface using some stain. Then lifting that upper lid to look at the superior sulcus and rule out superior limbic epitheliopathy. And then pulling down on the lower lid to assess lid laxity, that snap test, seeing how quickly those lids come back. Pulling up on the upper lids, checking for floppy eyelids, looking into the fornices, and then finally looking at meibomian gland expression by pushing on those lower lids and looking at the meibum that comes from them. So we always want to do a nice assessment of the lids and lashes. It's important to look at the base of the eyelashes to rule out Demodex blepharitis. And we know that simply by having our patients look down, we can look at the upper eyelid margins and see those collarettes being pathognomonic for Demodex blepharitis, and knowing that we should treat that as part of our ocular surface disease protocol, and also to clear both the lid margins and the meibomian glands. Next, we want to look at the lid margin itself, pushing on the glands to express meibum, ensuring that lid laxity and lid closure. And there's a reminder to look down to look for those collarettes on those upper lashes. We want to really identify in this stage blepharitis, nocturnal lag ophthalmos, floppy eyelid syndrome, a pterygium, epithelial basement membrane dystrophy, dry eye disease, and any related conjunctivitis like allergic or bacterial. This is the Korb-Blackie light test. This is where we're checking for nocturnal lag ophthalmos, and it's simple to do, but if you don't elucidate this being a problem at your initial dry eye exam, patients can go on for months with staining in the lower portion of the cornea, and you're thinking that you're treating them with maximum therapy and they're not getting any better. It simply could be because their eyelids are not sealing closed when they sleep at night. So I do this on all of my dry eye workups. I have the patient lean back into the exam chair and close their eyelids like they're sleeping, place the pen light right on the edge of their lid near the base of lashes, and then look for that light that's shining through the aperture where the two lids come together. If you see light shining through, then we know the patient isn't sealing their lids closed while they're sleeping and could have exposure keratopathy. I think it's important here to always make sure you check this in patients who may already have a bit of a floppy eyelid, or they're wearing a breathing device called a CPAP for snoring or sleep apnea. Here we have some images of fluorescein staining. It's important to note two things about fluorescein staining. It's preferred to use a fluorescein strip that you wet with saline and place in the eye instead of using fluoresce, which has a thicker viscosity in the drop itself. So using a fluorescein strip is number one. And number two is once you instill the fluorescein in the patient's eyes, wait 2 to 3 minutes before you look for the staining pattern. It'll take a moment for those cells to absorb the fluorescein and show those punctate epithelial erosions here in the lower image. There are several grading scales that you could use. I would just pick the one that your institution uses or your favorite one and stick with it. Lissamine green staining can be done and assessed at the same time as fluorescein. So in my patient workup, I put in a lissamine stain strip with the saline solution followed by a fluorescein stain strip and look at the staining patterns in both. Typically with lissamine staining, we are looking at the conjunctiva, although in more severe cases of keratitis sicca, we'll see that lissamine stain on the cornea as well. I like to use lissamine instead of rose bengal because it's a little bit less irritating and the grading is easy to assess very quickly. Here we're really looking, as I said, on the conjunctiva and assessing those goblet cells. Next, when you have the fluorescein stain in the eyes, it's a great time to assess tear breakup time or how quickly the tear film disappears once you have blinked a few times, and hold the eyes open and you simply count to 10 seconds to know what the tear breakup time is. So that is an easy way to do behind the slit lamp to evaluate the amount of lipids that are apparent in the tear film, because the more lipid the patient has in their tear film, the longer the tears are going to last on the front surface of the eye. And if there's less lipid in the tears, they'll break up faster. You don't need to use any significant imaging software or devices to measure this. You can simply do it within a slit lamp. You could also put a patient behind the keratometer, focus the Myers of the keratometer on the front surface, and count how many seconds it takes until those Myers break up. If you do have a more sophisticated piece of equipment in your office, then maybe it would give you a non-invasive tear breakup time, which means that we didn't have to use any staining to measure the breakup time, but that the device did it on its own. Schirmer's test. I don't know how common this is to do a Schirmer's test in your area, but I love doing Schirmer's tests in my office because it really gives me a sense of how much tears the patient is producing. And sometimes I'm surprised, even when I know a patient has Sjogren's disease, at how much or how little tears the patient is able to make. Now that we have neurostimulation drops and devices on the market, we can stimulate that tear production. And when I prescribe those devices and drops to my patients, I want to know whether or not they're working. So having a baseline Schirmer's test and knowing how many tears the patient could produce on their own is a great way to track progress when using other neurostimulation treatments or treatments that are to enable more productive tear volume in the eyes. So to do a Schirmer's tear test, you want to instill some anesthetic into the eye, and then pull down the lower lid, blot out the sulcus so there's no tears remaining, and fit that piece of paper to the side of their eye, the temporal edge of their lower lid, to collect tears for the next 5 minutes. So it's important to blot out the tear reservoir so that you're not soaking up tears that are already there, but truly measuring what tears are produced within that amount of time. So there we are with, I prefer to do this test with anesthesia because it is more comfortable to the patient that way. And then the Schirmer's test has numbers from 0 to 35 if they were able to fill the entire strip. And normal is above 10, and below 5 is pathognomonic for Sjogren's disease. And that might warrant further workup to indicate whether or not the patient has Sjogren's. And I always love to test corneal sensation on my dry eye patients to check for neurotropic qualities. Now, there are several devices available, the Cochet-Bonnet. There's a new device that puffs a little bit of air available from Brill Ophthalmics. However, most clinics are using something more simple, like a wisp of cotton from a cotton tip applicator or a piece of dental floss to touch the front surface of the cornea and evaluate the sensitivity. A reminder here to check corneal sensitivity, especially in diabetics and patients who are on at least one glaucoma medication, as that BAK that preserves our glaucoma medications can really have a profound effect on this corneal sensitivity. Here's a list of types of oral medications that could cause dry eyes. Unfortunately, many of our patients are taking these medications, such as pain relievers or antihistamines, on a regular basis without knowing the risk that they could be drying out their eyes and not knowing that that is what's causing their symptoms. Always look for these antihistamines, especially during allergy season when your patients may be complaining a little bit more about their dry eyes, and you can recommend some alternative allergy treatments instead of using decongestants and antihistamines for the long term. So let's dive into the treatment for dry eye and how the TFOS-DUES-3 report is driving the treatment algorithms. First, we always want to elucidate the root cause of dry eye disease. Could it be from the tear film, be it a systemic disease such as an autoimmune disease or Sjogren's syndrome? Medications, like I just reviewed, like antihistamines, oral hormone replacements, antidepressants could also be decreasing tear production. Now, the biofilm could be present with Demodex blepharitis, just having our patients look down, elucidating those collarettes on the upper lashes, or other forms of blepharitis, obstruction in the meibomian glands and atrophy of the glands, and then finally in inflammation such as ocular and facial rosacea. Always remember that the LIMP study showed us that 86% of dry eye patients demonstrated signs of meibomian gland dysfunction. And through the simple steps we reviewed earlier, we would easily be able to rule out some co-conspirators of dry eye disease in nocturnal lag ophthalmos with that Korb-Blackie light test, shining that pin light on the edge of the lid margin to elucidate an opening. The Demodex blepharitis, where we have patients look down in the slit lamp and look for collarettes. Epithelial basement membrane dystrophy using some fluorescein stain. Neurotrophic keratitis by checking corneal sensation with a cotton wisp. Allergic conjunctivitis, looking for papillae in the lower fornix. Floppy eyelid syndrome by pulling up on those upper lids and looking at how easily they open. And then the superior limbic keratoconjunctivitis by looking for the staining, fluorescein stain on the superior aspect of the cornea and conjunctiva. So we're going to dive into the three parts of the TFOS-DUES2 algorithm. This, I would this is part of the algorithm number 1 that I showed you earlier. The full algorithm picture is available on tearfilm.org or in the Journal of Ophthalmology when you can look at the Tear Film and Ocular Surface Society Dry Eye Workshop 3, look at their algorithms. What I've done here is just break down the treatments for the different layers of the tears. And right now we're looking at the treatment for the lipid layer. So some simple things that we can do for patients when they go home from our clinic is to prescribe lid hygiene, warm compresses, and blinking exercises. So these are simple things that our patients can do on their own. Lid hygiene could entail sprays, scrubs, or foaming cleansers that we could use to cleanse the lids and lashes. And I have a few slides later on where we'll go over those more in depth. And we could do warm compresses. I have a picture on the left-hand side of a microwavable mask that the patients put in the microwave for about 30 seconds and lay over their eyelids to allow the meibum to soften and be released from the meibomian glands. And then exercises, blinking exercises, having patients stop what they're doing when they're staring at their screens, their computers, their cell phones, and doing some really nice hard blinks to squeeze those meibomian glands and express the oily layer out onto the front surface of the eye. I've talked a little bit about tear stimulation. So we have neuromodulating eye prescription medications here in the US called Tripteer and Tyrvaya, and they work stimulating the trigeminal nerve to cause a basal tear to be formed on the front surface of the eye. The stimulation of that trigeminal nerve causes the lacrimal gland, the goblet cells, and the meibomian glands to secrete their portion of the tear film. Of course, we can also use punctal plugs to trap the tears on the front surface of the eye and use artificial tears that many of them are now available with lipids like flaxseed oil or omega-3 fatty acids in the formulation. If we move on to treating the mucin layer, we can look at topical anti-inflammatory prescription medications like steroids and immunomodulators like cyclosporin or lifitegrast. Tear stimulation, again, can be used because we know with neuromodulation and stimulating that trigeminal nerve that we get a full basal tear produced, and that basal tear would have components from the lacrimal gland, goblet cells, and the meibomian glands, getting that goblet cell secretion of mucins on the front surface of the eye. Tear stimulation devices are available that stimulate that trigeminal nerve within the nose. There's a device that stimulates it from the outside of the nose, and there's also one that goes into the nose and stimulates the trigeminal nerve from the inside, and that would give that full basal tear again. And then if you're looking to boost the mucin layer in your patients, you could reach for an artificial tear that had HP guar. These tears form a gel on the front surface of the eye and help to contain the moisture more optimally. One such tear is in the Sustain family, the Sustain Complete. And finally, for the aqueous portion of the tear film, we may want to reach for a nutraceutical like an omega-3 fatty acid supplement, or using Bausch & Lomb's NutriTears formulation, which has been clinically shown to increase tear production within 14 days. That is available over the counter. And topical anti-inflammatory agents would also boost the aqueous layer with steroids and immunomodulators. We could do something more sophisticated like autologous serum tears or platelet-rich plasma tears, using an amniotic membrane to heal the front surface of the cornea. Again, tear stimulation using the neuromodulation devices and drops. Tear conservation with using moisture goggles that may surround the ocular surface with a goggle that seals or a punctal plug. And of course, using artificial tears. I always recommend to my patients when I'm giving them an artificial tear that it be preservative free. In my clinic, I often like to send patients home with a care kit so that they're able to continue their dry eye therapy on their own on a regular basis. And the care kit would include an artificial tear, lid and lash cleanser, a warm compress, and then a nutritional supplement that would support the body to making healthy tears. In this section, I want to dive into some of the more advanced protocols and procedures. This is a device from the Alcon, which makes the Sustain Eye Lux. This is a device that heats the eyelid, melting the meibum, and then you manually express the meibum from the lid margins. And this is one that can be used right in the exam lane. It takes just 6 to 8 minutes to express the upper and lower lids, and gently heats and expresses the meibum right there on the spot. Tear Care is FDA approved here in the US in 2021. This is where we put the stickers of the device on the upper and lower lashes. It heats the glands to 115 degrees for 15 minutes. So the patient just gently sits with the device on their eyelids for about 15 minutes, heating up the meibum, and then the clinician returns to the exam room and it manually expresses the meibomian glands using the meibomian gland expressing forceps. This is LipiFlow by Tear Science and Johnson & Johnson. The LipiFlow is an activator that's placed on the eye and surrounds the eyelids. Then the patient is plugged into a device that gently heats the lids and expresses. It goes through a sequence of events heating those lids, and then the device itself has a bladder that pushes the lids into the device and expresses the meibum. It takes 12 minutes to do both eyes with this protocol. Another treatment that I use regularly in my clinic is Procara, which is a cryopreserved amniotic membrane. We now have this amniotic membrane on a ring or available to be placed inside of a contact lens and placed directly on the eye. I use this regularly in my patients who have a more moderate to severe dry eye disease, or maybe suffering from a corneal abrasion, a neurotrophic ulcer, or even sometimes in an infectious ulcer once we have had some adequate time in getting antibiotic on the eye to quell the infection, and then the amniotic membrane helps to prevent scarring. Next, we have intense pulse light. This is the OptiLight device that was FDA approved in 2021. The intense pulse light device uses photobiomodulation in order to put energy into the skin, which reduces inflammation around the eyes. It helps to gently shrink irregular blood vessels coming from rosacea in the cheeks and the eyelids that bring inflammation to the eyes. The light is warm enough or hot enough that it kills microorganisms around the lids and lashes, such as staph bacteria and Demodex. And it also melts the meibum in the meibomian glands. The energy of the light is specific to stimulate the mitochondria in the meibomian glands and help them to heal, decrease inflammation, and produce better quality meibum. Generally, when we're using the OptiLight protocol, we do a series of 4 sessions on a patient here in the clinic, and the sessions are separated 2 to 4 weeks apart to allow the skin time to recover in between, and doing an expression after each treatment to express the clogged meibum from the meibomian glands. Studies have shown that it gives an increased or improved tear breakup time and significantly changes the quality of the meibum and improves the expressibility and the number of meibomian glands that are able to be expressed after those 4 sessions. Another device that I routinely use in the clinic is radio frequency. There are monopolar and bipolar radio frequency units. Basically, these devices are doing a deep heating of the skin around the eyes to penetrate the meibomian glands, heat those glands, and make the meibum more expressible. It also will stimulate collagen production in the lid area, reducing wrinkles and telangiectasia. I don't currently have low-level light therapy or LLLT in my clinic, but their studies have shown that this light can help to direct photobiomodulation, just like intense pulse light does, putting that energy into the mitochondria of the meibomian gland cells and healing those cells, as well as being able to liquefy the meibum. It is nice using this device because it's not required that the patient has a certain skin type. Any skin type can use it, and it can be helpful in treating dry eye, meibomian gland dysfunction, chalazion, rosacea, demodex, blepharitis, and even using it post-blepharoplasty. Oh, it looks like we are running out of time. So I will go ahead and stop right here. And next time we'll talk more in depth about the second algorithm in the TFOS-DUES-2, which looks into anterior and posterior blepharitis. Let me just scroll down to my last slide here so that I can place my contact information. If you have further questions about anything that I reviewed in this presentation, I would be happy for you to reach out to me. The easiest way is through LinkedIn, but if you would like to send me an email, my email is there on the screen, as well as my website, which has lots of information on treating dry eye disease. Thank you so much for your time, and I appreciate your attention.
Thank you, Pam ma'am, for your insightful and beautiful presentation. It's really very good to hear from you. Thank you, ma'am.
Thank you.